So, hello everybody. Welcome to the mental health lunchtime webinar. I wish you a pleasant time of the event and wherever you are. But basically, it's lunchtime for Europe and surrounding countries. We will have very interesting topic today, and I'm looking forward to hear from our presenters. I have some technical things at the beginning. Just for your information, it's always interesting to hear that we have 221 registered people, but the attendance is always a little bit lower from 40 countries around the world. It's always like wow effect. Who is watching the webinar now and from where? I have one request from the side of ECFS, from the organizing part of the webinar. There is a short questionnaire at the section of question and answers, Q&A section. It's only 3 questions concerning our webinar. The questions are: did you find the webinar useful? Did you learn something new here? And what other webinars around CF mental health you would like to see? It will appear in the Q&A section. It would be very nice of you if you respond. You must not, but we will be very thankful to you. And the answers are for us just to see if we do our work good and what other topics you want to hear and see. So please look at the section. It's the section Q&A where you can put your questions and we try to answer it at the end of the webinar. We hopefully will have time for discussion at the end of the webinar, but currently we have a lot of questions from you, so I hope we will have time to answer them all. If not, we will try to answer it via email, or you can directly ask the presenters about their opinions. So the first speaker is Dr. Cian Greene from Ireland. I will tell you some things about him. He's a registered nutritionist and postdoctoral researcher. I'm sorry about my English. When I'm nervous, my English is getting worse. He completed his PhD in January 2026 at the School of Allied Health at the University of Limerick. He is supervised by 2 professors, Audrey Tierney and Katie Robinson, and his research explores directly the topic of our webinar: nutrition, diet quality, and lived experience among adults living with cystic fibrosis in the modulator era. His work aims to support more person-centered practical nutrition care by combining research evidence with the voices of people living with cystic fibrosis. That sounds very good, so Cian, you can start.
Thanks very much, Pavla. So good afternoon, everyone, and thank you for the opportunity to speak today. Today, I want to take you through a journey, not just of findings, but of how we arrived at an unexpected and increasingly important area in cystic fibrosis care: body image. This wasn't where the research started, but it's where it led us. Okay, so originally our project was funded through the HRCI-HRB joint funding scheme with the valued support of Cystic Fibrosis Ireland. The project then received further funding through Research Ireland's Government of Ireland postgraduate scholarship as part of my PhD, which enabled continuation and expansion of the original work. And really, this work sits within a period of enormous progress in CF care. As you all know, we've gone from survival into early adulthood in the 1980s to now over 50 years in many countries. But with that progress, we're seeing a new challenge emerging, with over 40% of individuals now living with overweight or obesity. So the landscape has fundamentally changed. And much of this change is tied to major treatment advancements, particularly CFTR modulator therapy, which has improved lung function and overall health and has been associated with changed nutritional and metabolic outcomes. At the same time, nutrition has long been a cornerstone of CF care. The legacy diet, high calorie, high fat, alongside enzyme therapy, was critical in improving survival, and importantly, it worked. But the question for a while was, does it still serve us in the same way? So we began by asking a very simple question: what are people living with CF actually eating, and what does this look like compared to CF-specific and general population nutrition guidelines? We eventually produced a systematic review on the topic, which was published in the Journal of Cystic Fibrosis in November 2023, which I'll discuss next. So to capture the full scope of the literature, we searched 5 major databases from inception to April 2023, which yielded just over 6,000 records. After screening and eligibility assessment, 21 studies were included. These represented 19 distinct cohorts, with a total of 724 adults living with cystic fibrosis. So overall, this provides a fairly comprehensive picture of the available evidence in this area. And the key results from this were somewhat unsurprising. Most adults met or exceeded CF-specific energy and fat recommendations. However, there was limited data on diet quality, and of the 4 studies that did assess diet quality, all reported suboptimal dietary patterns. And supplements assisted in achieving most micronutrient requirements. So already we had our first signal. The problem may no longer just be intake, but quality too. And that raised a critical question. Is our nutritional model still aligned with the needs of the population? So we designed a mixed method study to capture both the numbers and the lived experiences behind them, working closely with Cystic Fibrosis Ireland's Public and Patient Involvement Group to keep it grounded in real world priorities. So I'll start by discussing the quantitative component. We wanted to understand not just what adults with CF in Ireland are eating, but also the overall quality of that diet, and importantly, what factors might be influencing it. This resulted in 2 key outputs. First, a paper describing dietary intakes and diet quality in Irish adults with CF within the modulator era. And second, an analysis exploring how diet quality relates to health-related quality of life. And what's important here is that this moved us beyond a traditional focus on calories and nutrients towards understanding diet as part of a broader health and well-being picture. So just briefly to contextualize the cohort and the approach. Through partnership with Irish CF Hospitals and CF Ireland, we recruited a group of 68 clinically stable adults with cystic fibrosis, mostly on modulator therapy, so very much reflective of the modern CF population. Importantly, over a third were living with overweight or obesity, with very few underweight, highlighting that shift away from the traditional phenotype. In terms of methods, we used 3-day food diaries alongside health questionnaires and validated patient-reported outcome measures, so we could look at diet in the context of symptoms, quality of life, and overall health. And analytically, we compared intake to CF-specific and general population nutrition guidelines, assessed diet quality using 2 diet quality indices, the Healthy Eating Index 2020 and Diet Quality Index International, and explored how they related to health-related quality of life. So when we look at dietary intakes in this group, it really reflects what we're seeing globally. There's high fat, sugar, saturated fat, and low fiber, low fruit and veg, and micronutrients. There's also a strong reliance on energy-dense, nutrient-poor foods. And when we score diet quality, when compared to evaluation criteria for each score, they fell within the lowest grades, reflecting poor diet quality. Yet, about half still aren't eating energy requirements. So despite that long-standing focus on high energy, we're now seeing diets that are both imbalanced and not consistently meeting needs either. So we then looked at health-related quality of life. And what really stood out to us here was the overall symptom burden in this cohort. Vitality was the lowest scoring domain of the Cystic Fibrosis Questionnaire revised, and a substantial proportion of participants reported anxiety and depression, as well as pain and discomfort. Gastrointestinal symptoms were also highly prevalent, particularly bloating, which many rated as moderate to severe. So this is not a population that is symptom-free, despite significant advancements in treatment. But interestingly, body image did not emerge as a major issue within the quantitative measures, and that became important later. We then looked at how diet quality relates to broader health outcomes. After performing multiple linear regression analyses, FEV1% and digestive symptoms as measured by the CFQR were independently positive, significant predictors of the Healthy Eating Index 2020 scores, suggesting that dietary patterns supporting gut health may play an important role in long-term well-being. It must be noted, however, that associations with FEV1% may be indirect, resulting from changing dietary priorities as CF health concerns improve, whereby the primary focus may have shifted from survival to prevention of chronic disease progression, which is reflected in literature by Snowball and colleagues in the UK. But overall, the findings begin to shift the focus from simply meeting energy requirements towards diet quality, symptom burden, and longer-term health outcomes. But even with this more complete picture, we were still missing something. The quantitative data could tell us what people were eating and how that related to symptoms and quality of life, but it couldn't tell us why. Why dietary patterns looked the way they did, why certain behaviors persisted even as the clinical landscape was changing, and how individuals were actually experiencing these changes in their day-to-day lives. And that's when it was made obvious that we needed to move beyond the numbers and start listening to the lived experience. So this led us to the qualitative phase of the study, which became a real turning point in the project. Up to this point, we had strong understanding of dietary patterns and the relationship with health outcomes. But this phase allowed us to begin exploring the experiences behind those patterns. And as we'll see, it took the research in a direction we hadn't originally anticipated. So to explore this further, we engaged directly with participants from the quantitative study. Those who had already taken part were invited to continue into the qualitative phase. We conducted semi-structured interviews and focus groups, co-designed with our Public and Patient Involvement Committee, allowing participants to reflect on their experiences in their own words. And the data were analysed using reflexive thematic analysis, an approach that centres participants' voice while also acknowledging the role of the researcher in interpretation. And through this process, we developed a number of key themes. What became clear very quickly was that people's relationship with food had been shaped over a lifetime. There was a strong legacy effect where high-fat, high-energy eating was deeply embedded, often linked with anxiety around weight and health. But at the same time, participants described a shifting relationship with food, moving from obligation or even pressure towards more choice and autonomy in the modulated era. And alongside that shift, new challenges began to arise, particularly around weight gain and changes in body image. Participants spoke about feeling different in their bodies, navigating visibility, and trying to reconcile these changes with their sense of identity. There was also a sense of reclaiming control, sometimes pushing back against traditional clinical advice and wanting to make their own decisions. And finally, the reality of daily life. Fatigue, time, finances, and emotional well-being all played a significant role in shaping dietary choices. So overall, what we see is that diet is not just a clinical behavior, it's deeply personal, shaped by history, identity, and lived experience. And it was within this context that body image surfaced as an important and previously under-recognized issue. So bringing the mixed methods project together, first, our findings suggest that we need to move beyond energy alone and focus more on diet quality. Second, care needs to be individualized. One size fits all no longer works. And while tools like the Healthy Eating Index are useful for research, in clinic, they're not practical under time constraints. Looking ahead, we need longitudinal studies to track diet quality, gut health, and cardiometabolic outcomes over time, behavioral interventions aimed at improving diet quality, and importantly, continued multidisciplinary and patient-led approaches. And additionally, body image concerns were coming up repeatedly in participants' accounts. And yet, this wasn't something that had been captured in the quantitative data or fully explored in the existing literature. So this led us to ask a new question. What do we actually know about body image in CF? And that led us to a systematic review focused specifically on body image and cystic fibrosis. So before looking at the evidence, it's important to consider how body image in CF has evolved. Historically, body image in CF was shaped by a very different phenotype, one characterized often by low weight and frailty. And this interacted in complex ways with societal norms. For example, a critical review from Tierney in 2012 reported that many females aligned with cultural ideas of thinness despite health risks, while males often experienced dissatisfaction with smaller body sizes. But the introduction of CFTR modulators has fundamentally changed that landscape. We're now seeing significant improvements in health in many, alongside increases in weight and BMI. And this creates a new tension, because while the clinical picture has changed, our understanding of body image has not kept pace. So the key issue is that body image in CF has not been systematically re-examined in this new context. And that is exactly what we aim to do. And the findings of our systematic review should soon be available to you, with the manuscript being accepted for publication in European Respiratory Review. So we searched across 5 major databases from January 2011, when the last critical review on the topic occurred, to August 2025, identifying just over 500 records. After screening, 29 studies were included. These were predominantly quantitative studies with only a small number of qualitative and mixed methods papers. And importantly, these studies spanned different phases of CF care, from the pre-modulator era through early rollout to widespread use. We then completed a narrative synthesis of the findings across these time periods to understand how body image has evolved alongside treatment advances. So when we look at how body image has been measured in the CF literature, most studies rely on CF-specific quality of life tools, particularly the Cystic Fibrosis Questionnaire Revised. And what these studies show is across all treatment eras, from pre-modulator through widespread modulator use, body image scores remain only low to moderate. So despite major improvements in survival, health, and weight, there's no clear evidence that body image has improved alongside them. Instead, from the current evidence, body image seems to be shaped more by broader aspects of health and functioning. Psychological well-being, physical and functional status consistently present as the most consistent predictors across eras. And what's particularly interesting, though, is that these drivers appear to shift over time. In early studies, body image was more closely linked to BMI and the female gender. But in more recent studies, those relationships are much less consistent. So while body image is present, the quantitative literature doesn't fully explain how or why it is changing in the modulator era. So having seen the quantitative picture, we then turn to lived experience. And from these experiences, it's clear that body image is viewed as important in adults living with CF, but rarely addressed in CF care. There's also uncertainty around who should initiate these conversations, but a preference for clinicians to lead. Early eating experiences continue to shape how people relate to food, which aligns with our Irish Studies first theme. And we also see a clear tension between clinical weight goals and personal body image, reflecting our theme of reclaiming authority over the body. Qualitative accounts also demonstrate that body image is still influenced by gender, physical changes, and society and social comparison. And importantly, there's a strong emphasis on empathetic, non-weight focused care and attention to psychosocial well-being. So overall, there's clear alignment between the wider literature and our own findings, showing that body image in CF is shaped by far more than weight alone. And once we recognize that, it raises the question, are our current tools actually capturing body image? And this is where we start to see a clear measurement gap. The tools we rely on, like the CFQR and the CF-QAL, are rooted in historic CF phenotypes, with questions framed around underweight experiences. But the reality has changed for many. We now have individuals who are overweight, living with obesity, or experience rapid body composition changes. So the issue isn't that the tools are wrong, it's that they're misaligned with the current context. As a result, they begin to underrepresent the types of distress we're now seeing. And that leads to the key insight that these tools may be missing important aspects of body image because they're asking the wrong questions for the modern CF landscape. So to bring this together, body image disturbances in CF haven't disappeared, they've evolved. In the pre-modulator era, the focus was on difficulty gaining weight and appearing visibly sick, whereas now body image appears to be more closely tied to physical health, functional capacity, and weight gain. Gender differences may still be present, but they've shifted. For example, we now see distress around weight gain or bloating. And in terms of food, we've moved from forced high-fat intake to more restrained or strategic eating behaviors. So the key message is that despite major clinical advances, body image disturbances remain, but they're no longer driven by weight alone. They're shaped by psychological, functional, and social factors. And that's why moving forward, we need more holistic support and tools that actually reflect the modern CF reality. So what do these findings mean for practice? Overall, they point to a shift from weight-centric care to more well-being focused care. First, there's a need to update our measurement tools. They were developed in a very different clinical context and don't fully reflect the realities of the post-modulator era. And while we wait for the potential development of a CF-specific tool, it's important that clinicians don't hesitate to engage. We need to begin conversations around body image. Historically, this hasn't been routinely discussed, so it likely needs to be introduced proactively and built into care. But it's also important that these conversations are introduced strategically and sensitively. And third, there may be value in moving towards more weight-neutral approaches, shifting the focus from BMI alone to metabolic health, emotional well-being, how people actually experience their bodies. And ultimately, patients who spent their lives trying to gain weight are now navigating a very different reality. So care needs to evolve with that, becoming more personalized and responsive to both the physical and the psychological transition. So just to finish, I'd like to thank all of our collaborators, funders, and participants who made the work possible, as well as my amazing supervisors for my PhD, Professor Audrey Tierney and Katie Robinson. And thank you all very much for your time and attention. I'd be happy to take any questions at the end.
Thank you, Kian. It was excellent. It's a great introduction into the topic, and it combines nutrition and the psychological side of it. So thank you very much. I hope we will have the question, but we will let them at the end of the webinar. Okay, thank you again. So the second speaker is Kay Vavrina. She is from US, and she's completing her Doctor of Clinical Nutrition degree at Rutgers University. And the research is focused on growth outcomes in children with cystic fibrosis in the era of CFTR modulated therapy. But to start from the beginning, she is a clinical dietitian with more than 25 years of experience, specializing in cystic fibrosis, gastroenterology, and complex digestive disorders. And she is focused on both pediatric and adult populations. So we are looking forward to your presentation, Kay.
Hello, everyone. Thank you so much for having me here today. I'm very just grateful to be here. So today I wanted to present, my colleagues and I published a paper last year evolving nutrition therapy in cystic fibrosis, adapting to the CFTR modulator era. And so what I wanted to do was focus on some of the changes that we are seeing in the modulator area with a focus on comorbidities and how they may affect body image in the people that we take care of every day. Like Kian was mentioning earlier, there has been a focus on weight gain, BMI, and adequate nutrition. And this dates back to the Corey study, which I'm sure we're all familiar with, that compared people with CF in Boston who followed a low-fat diet and people with CF in Toronto, where they focused on a higher fat diet and took high doses of enzymes. The people in Toronto were found to live longer, weigh more, and be taller than the people with CF at the Boston Center. This has led to the guidelines that we have been focusing on for such a long time, focusing on the high-fat diet, the weight gain, and promoting nutrition overall. It is well documented that ETI therapy results in increased weight gain and BMI in many people with CF who are taking this therapy. Adults and adolescents in particular are particularly vulnerable to body image issues. And this is, like Kian mentioned in his presentation too, that this is probably due to the historical focus on weight gain, nutrition, and BMI. There was a study by Lyons et al. That found that looking at 52 adolescents and young adults in CF found that most of them who were reported taking ETI, they described themselves as very adherent to their therapies, that they took their medication 80 to 100% of the time. But whenever, and this is very similar to Kian's research, that whenever this is posed in a different way, whenever they were asked the questions and asked to use a Likert scale, and when their statements were analyzed, 31% of the participants reported that they had a slight or strong agreement with statements such as, "I do not want to take ETI because it causes me to gain weight." There was also a significant relationship found between adolescents and young adults with CF who reported body dissatisfaction. And this again is related to males and the smaller body, and then males having a smaller body and wanting a larger body, and females wanting a smaller body. And so that's 74% of females wanting to have a smaller body compared to 48% of males. like Kian mentioned, also, we have a lot of similarities in our presentations. There was a study done in 2012 by Stephanie Tierney and colleagues, and she reported that males were more likely to have a poor body image because of the undernutrition that was prevalent at that time. And so, with the male focus on wanting a larger body, them having that smaller body at the time was creating their poor body image. So we know that over time, ETI has not only changed body image, but whenever we look at the comorbidities that are traditionally related to CF, those have also changed. The better nutrition and overall lung function of people with CF has improved their nutritional parameters. These numbers are based on recent US CF registry data, but we've seen an increase in BMI overall from 20.9 kilograms per meter squared to 23 kilograms per meter squared. And this is with ETI treatments. We've also seen a rise in overweight and obesity rates from 8.3% before the availability of ETI to 22.9% after a year of treatment. When we think about the traditional risk factors that are associated with overweight and obesity, we can think about how they may affect cardiovascular disease in the future. I really wanted to focus on metabolic syndrome and CF-related diabetes because there is a small amount of research that these conditions are related to a poor body image. Historically, we did not consider these comorbidities a risk in the past because our patient population unfortunately did not survive long enough for these to become a concern. Concerning metabolic syndrome, which is a combination of impaired fasting glucose, low HDL, hypertension, truncal obesity, and hypertriglyceridemia, there were some researchers that at the University of Texas Southwestern Adult CF Center, and they looked at their patient population who attended their center, and they measured the people meeting the metabolic syndrome criteria. And that number, after a year of treatment with ETI, increased from 13 to 30. And whenever they compared them to their population that was ineligible for ETI, that ineligible population did not experience any increases in the metabolic syndrome criteria. So we see that as people age, they are becoming more at risk for metabolic syndrome. We also know from our experience that as people with CF age, their risk of developing CF-related diabetes does increase. Looking specifically at body image and metabolic syndrome, we don't have data, of course, on our CF population particularly, but what we do have is data from other populations. And so looking to that literature, there was a Korean study that analyzed data from normal weight adults with metabolic syndrome. And what they found was out of 6,479 participants, 58.1% of them did not perceive their body image as any different. They considered it normal. But 41.9% of participants did have a distorted body image. And in that 49.1%, 26.5% of them perceived themselves as underweight. There was also a gender-dependent difference in body image perception among these normal weight adults, and that was found to be statistically significant. Men, the larger proportion of them, 48.8%, they had a distorted perception of themselves being underweight, while only 4.1% of men had a perception of themselves being overweight. The opposite occurred in the female population. There was 36% of them who perceived themselves as being overweight, and a larger percentage of them perceiving themselves being overweight at 18%. Looking specifically at CF-related diabetes, we know that this is going to, the incidence of CF-related diabetes is going to increase as our population ages, and possibly we may even see some type 2 diabetes increasing. There was a longitudinal study of adults in a single CF center in the UK by Abbott et al., and they showed that having CF-related diabetes is negatively associated with body image. Again, we don't have a lot of guidance on this or information at this point, and so we look to other populations. And as CF-related diabetes advances and people become more insulin dependent, this may affect body image as well. There was a study done in children with type 1 diabetes who were receiving insulin via continuous subcutaneous injection, and they found that to be negatively associated with body image. Looking at adults with type 2 diabetes, Herzog-Ramos et al. Found that half of their participants were dissatisfied with their body's appearance. So we do have some evidence already that CFRD is related to negative body image. And as this comorbidity worsens, the added requirement of insulin will possibly add to this problem. So what can we do? What are we doing? This in the US, we have not really published any particular guidelines. There's a little bit of guidance out there for us, but the CF Foundation is waiting for more research for us to actually change our guidelines. But the European guidelines, of course, have been published. And these are very similar to what we would recommend for the general population: maintaining a healthy weight, increasing fruits and vegetables, whole grains, limiting sugar, salt, and fats. Of course, we do have to individualize this approach and use our clinical judgment to see what each patient does really need. Nutritional counseling is likely going to become a more increased focus, because we do need to address the challenges of the diet modulators and initiate behavior change. So in conclusion, we know that a lot has changed in how we manage people with CF in the ETI era. The improved lung function and increased resting metabolic rates have increased the rates of overweight and obesity. Looking ahead at comorbidities, CF-related diabetes and metabolic syndrome may contribute to a distorted body image. And while we continue to work on how to manage these issues, we will continue to do more research. Thank you all for having me. I am happy to take questions at the end.
Thank you very much, Kay. You pushed the topic forward after the Kian introduction. For me, is especially interesting the topic of individualization of nutrition counseling and based on ETI and the view of the patient and how they perceive themselves. So I hope there will be more questions for you at the end. And let's introduce the next speaker. This is Florine Balke from Belgium. I will read some facts about you, Florine. Florine is currently completing her final year of communication sciences at Ghent University in Belgium. And she has previously shared her insights through the Instagram platform Long Story Short. It's a very interesting name of the platform. And at the European Young Investigators meeting. And beyond her studies, Florine is the chair of the local youth council and a lead coordinator at a playground. So let's share your experiences, Florine does.
Yes.
And Florine is a CF patient, but I think you understood.
Yes. Thanks for the introduction. I will share my presentation. Yes. Can you see my presentation? Yes.
Yes, we see it.
Yes. Okay. Yes. Good afternoon, everyone. My name is Florine. I'm 21 years old, and I live in Belgium. I live in Ghent, a student city. And yes, I'm currently finishing up my degree in communication science. So I am almost graduated. My story with cystic fibrosis started almost as soon I was born. My parents found out I had CF when I was just 2 months old. But before I started what I called the miracle drug, Kaftrio, my life was basically a constant battle. My life was a battle. I did physiotherapy twice a day. I took 25 pills every single day. I often needed to go to the hospital for IV antibiotics. In primary school, I managed okay, but things got a lot tougher in high school. My lung function dropped to around 55%. And while my classmates were around with friends or going out to parties, going to sweet 16s, my life revolved around 14 hours of therapy in a week. At that point, sports weren't a hobby anymore. They were a bitter necessity to just keep my lungs as healthy as possible. But my lungs weren't the only struggle. When I was younger, my 3 biggest challenges every day were breakfast, lunch, and dinner. Every meal was a fight. I hated eating. I took so long to finish a plate that my parents often had to sit next to me for an hour to just get me through it. And sometimes, despite all mine and their effort, just eating for 1 hour, at the end, I threw everything up. I was constantly losing weight, so I had to see a dietitian to force down as many calories as possible. It didn't matter if it was healthy or not, I just ate to survive. Chips, cookies, fries, everything. As a child, I didn't care about how I looked on the outside. I only cared about how my body was functioning on the inside. But that changed in secondary school. Like any teenager, I became insecure about my body. I was pale, thin, I felt restricted. While my classmates were joining youth movements or going to summer camps, I was always told no. No camps. I wasn't allowed to play musical instruments, no exhausting or dirty or unhygienic activities for me. All the time I went to therapy and sports. My body felt like a cage that kept me from being a normal girl, that kept me from being myself. And deep down, I knew I was different. But on October 9th, 2018, everything changed. When I joined the clinical trial for Kaftrio, my lung function jumped from 55% to 85%. But the transformation was much more than just that number. I changed physically, you can see. I gained 10 kilos and finally reached a healthy weight. When I looked in the mirror, I saw a young woman instead of a patient. I didn't just get color back in my face, but the color back in my life. But more importantly, I changed on the inside. People around me, friends or parents, told me my character has shifted. I became more open, more social. I was more confident, also more confident in groups. And I was finally becoming myself. But, however, there is another side. Kaftrio has given me a much better life, for sure. But it hasn't cured me. I still deal with mucus every day. I still need physiotherapy for 1 hour every day. And sometimes I still will feel very sick or feel short of breath or just exhausted. But in those moments, I think I'm unconsciously trying to compensate or start paying way more attention to my clothes and how I look. My physiotherapist actually pointed this out recently. I was struggling, coughing up a lot of mucus, and she said to me, Florine, when you don't feel good on the inside, you seem to feel the need to look extra good on the outside. So she looked at me and she said, yeah, you look very good. So honestly, I took that as a huge compliment because it's so true. In the moments when my body is letting me down internally, I want to look radiant on the outside. It's my way of taking back control, I think. I don't want the world to see that failure on the inside reflected on my outside. Since Caftrio, two things have emerged that created a bit of a paradox in my life. Let me explain. On the one hand, I have the incredible zest for a life and a major case of FOMO, the fear of missing out. I want to be everywhere, every party, every event with a dance floor, every fun moment with friends. I'm not the type to turn down a dessert, a glass of wine, or a cocktail, or maybe three, but because I want to enjoy life so intensely. I know exactly how fast things can take a turn for the worse, so I really want to squeeze every single drop out of life. But it's a paradox. On the other hand, I feel the deep need to take extremely good care of my body. I want to feed it, not just fill it. And that's why I sport a lot. I run. I love running. I run sometimes 5K, sometimes 10K. And I also did some half marathons. That's also why I visit an osteopath to learn how I actually read my body's signals. I've really dived into nutrition to avoid those sugar crashes I used to get. And I spent a lot of time listening to podcasts about food, about nutrition, about how to manage your energy, just how the body works. It's all part of finally getting to know my body and also my female body. I'm very interested in women's health and try to understand my cycle, etc. But the biggest quest remains identity. When your whole life is revolved around being patient, it's hard to know who you are without that label. Without that label. For years, cystic fibrosis decided what I could and what I couldn't do. Sometimes I still have to study from a hospital bed. For example, in my first exam period, I studied in the hospital. But however, the world is more open to me much more often now. Research gave me better lungs, but more importantly, it gave me the freedom to choose who I want to be. I'm no longer just the girl with CF, because I was. I'm a student now, I'm a young woman, I'm a runner, I'm a tennis player, I'm a friend, and I'm also a partner. But to be honest, I'm still figuring it all out, just like everybody, I think, because I never really got a chance as a child to explore who I was back then. And yeah, I still don't fully know who I am, what I truly love, or what I exactly want to do in my life. But that's why I'm trying everything right now. For example, I'm testing all kind of sports, from running and tennis to fitness and dancing. I even try to teach myself how to DJ. And every summer, I make it a point to take different jobs, different student jobs every summer, just so I can experience as many things as possible. I've also become very active in different organizations to learn about myself, to develop myself. I'm currently the president of the youth council and a lead counselor at the playground. I love meeting new people and just putting myself out there. After years of being told no, I'm finally discovering the person I always meant to be. So yeah, I can't wait to discover the rest of my hopefully very long life. Thank you so much for listening to my story. If you have any questions, please feel free to ask.
Florine, thank you very much for your presentation.
Yes.
Yes, it was full of for me very interesting and touching moments when you said, for example, that you want to feed your body and not just fill it. It's a good point, and I'm very happy to hear that you are more open and you are trying to find yourself. That's the life for, and to find who I am and what I want. So thank you all very much, and we have several questions. I will try to read them. The first question, I don't understand it fully, but maybe we can try to find the meaning of it. Do we need to change the patient experience questionnaire? I don't know if somebody of you understand what questionnaire. Maybe it's a reaction on PN presentation that we need to find something to.
Yeah, certainly. I think in relation to body image, there needs to be an adaptation of the questionnaire. It's still focused very much so on an underweight phenotype, and it's not really able to capture any of the modern concerns that many people with CF are living with in relation to weight gain and rapid weight changes. So there certainly needs to be an adaptation or a new questionnaire developed. And in the meantime, while we can't really sit on our hands and wait for that questionnaire to be developed, there are tools out there that can be used in the meantime to identify body image or eating disorders in people with CF. And that's, I believe, Emma Lyons in Colorado highlighted that well in one of her papers. For example, a tool like the Eating Attitude Score, EAT 26, can be used. And there's a number of questionnaires that can be used that are more tailored to the general population to examine body image, but in the future we certainly do need a CF specific tool.
Thank you. Kay, do you want to add anything to it?
No, I agree 100%. It does need to be modified, but I mean there are some tools that you can use to apply, and then of course use your clinical judgment to decide on a path forward.
Okay, thank you. Maybe it's a challenge for cooperation between psychologists and nutritionists to make a new questionnaire, CF specific.
Yeah. I think as well as that, there's something additionally that needs to be considered, the fact that, in clinic, a lot of the time people have limited amount of time. So you need to find a tool that's going to be very quick to use. Yeah. And some clinicians might not have time to use a tool like that and might just need to bring it up in conversation, again, in a sensitive manner. But it's time constraints is also another thing to consider in the development of a tool.
Okay, thank you. The second question, do you think the introduction of modulators has had an impact on prevalence of disordered eating? Do you see increasing prevalence of disordered eating? It's also a question for colleagues of psychology, if you see that.
I don't work in clinic as a practicing dietitian, so I might leave that open to other people.
For me, I would say that it's hard to tell for sure. And I don't know if it has really increased the amount of body image dissatisfaction that we see, but I think it has changed it. I think it has evolved from I'm too thin to, now I've gained too much weight. And so I think that's the difference that I have seen.
Yeah. It may lead to disorder when I see myself as too fat or overweight or obese. I can develop eating disorder. Yeah.
Mhm. Is
Okay.
it not also changing of habits, lifetime habits, that previously were, good habits, but now maybe not so good habits anymore? On the other hand, I heard Florine say, I used to have not so good habits, and now I'm exploring. Maybe Florine, you can add, because your story is not necessarily, developing disordered eating, but maybe improved eating.
Yeah, I understand. Before, I need to eat everything, between lunch and dinner, I had to have snacks. After dinner, again snacks, and then you're doing that also after cardio, but that's not really good if you do that. So that's a shift mentally for me. You have to learn it not to eat always.
Well, could I further ask a question on that, Florine? Because I agree with Trudy. It's a change in habits.
Yes.
And I think it's a change in your relationship to food, and also beforehand, food was how much you can consume and get in,
Yes.
and now you can perhaps enjoy it, or you have more autonomy over
Yes.
your food choices. So I wonder how your relationship to food has changed, and are you able to enjoy it more and see it less as a medicine and more as a
Before I hated eating, and I don't know why, because now I love eating so much. I looked forward to every meal, and sometimes I find it kind of sad that I am not allowed to eat everything. My relationship with food is really good, but I mean, I don't think that's something with cystic fibrosis, but every woman in their puberty and even in their 20s or maybe older, that food is something you always think about, because as a woman we need to get skinny, and we see it on social media that everyone is looked really beautiful and shows his prettiest side. So it's something, as a woman, I really can how do you tell? Yeah, I can relate with a lot of women. So food is something. Yeah, sometimes it's medicine or something really good, and sometimes you think a lot about what eat and how many calories are there, and yeah.
Thank you. I will go on with the questions. Some practical ways in which dietitians can help young people with body image issues and CF within scope of practice. And there is another practical question bonded with it, I should say. How can clinicians practically support people with CF to adjust to acceptance of a changed body image? So I think this is the question on our nutritionists here.
Yeah, I would say for me, the focus that I have tried to take is more of a non-weight focused approach, and move away from that focus on the number, because we don't really want to treat the number, we want to treat the patient. And moving away and looking at different markers that of health. Say for instance, someone, has an elevated lipid panel now that they never had before. So let's not focus on the fact that it's because your BMI has increased. Let's focus on changing our diet to get these numbers changed so that you can prevent comorbidities in the future. And so that's one of the ways that I would, try and go about it. And the other thing that I would do is, just make one small change at a time. If you are, eating butter on every single thing that you eat, try at one meal a day to, just put it on your bread or something along those lines.
I would entirely agree with you as well, Kay. Definitely needs to be more of a weight neutral approach not to worsen body image. If you don't come at it from a weight neutral approach and you start looking at BMI, you can make the problems worse. So coming from a weight neutral approach, focusing on, like you said, lipid markers, and if you're looking at the things that body image is revolved around, it's around, how capable someone's bodies are, more so than weight at the moment in CF. It seems to be shaped around functionality. So if we focus on improving those kind of aspects as opposed to singly on weight, I think it can make a lot of difference.
Yeah, the other thing I probably should have mentioned is that all of the work that's being done on body composition right now, and hopefully we'll have a good measure of body composition that we can use, out in the field, so to speak, in clinic. That would be a better marker of overall health than just BMI.
Okay, thank you. Do you, as dietitians, provide diet education during annual evaluations? Do you provide it with every patient or not? And how do you navigate conversations of weight loss and Ozempic and sort of things? GLP-1, it's the name.
Mm-hmm. So for me, I don't have to do diet education at every visit for every person. This is something that has been talked about for them their whole entire life. And so really it's more about turning it to the focus of the other markers of health, for instance, your lipid panel or, lean muscle mass. And so that's not appropriate for every patient. Every patient doesn't need to have this conversation. And they definitely don't need to have it, 20 times in their life. So in general, it's using other methods to focus on what would be a catalyst to have them choose healthier foods. And what's the second question? I forgot the second question.
Conversations about weight loss and help of GLP-1 medication.
Yeah. I think actually for us as people who take care of people with CF, this conversation is easier to start than it would be for, someone who, say doesn't have a chronic health condition. Because we've talked to them about their weight their whole entire life already. And so using, again, like, we were mentioning before, it's not focusing on that number, so to speak, but, for instance, if you're looking at a growth chart, focus on the trend or, focus on the ability to, keep up with your toddler running around in the house, using these things. But, I really feel like our population is more open to discussing this than other populations might be who have not had, this conversation their entire lives. And, even other conversations that are probably more embarrassing to them. So I do feel like it's a little bit easier for us.
Thank you. Kian, do you want to add something? Do you make this annual conversation with every patient, or you don't work in clinic?
No, I don't work in clinic. I'm primarily just a researcher, so yeah, I can't comment on this, unfortunately.
Okay. So, and the last question, I'm sorry, we have a lot of questions, but do you have any specific recommendations for supporting people with CF who struggle with diet changing after starting modulators? Any specific recommendations?
Yeah. My number one recommendation would be change small things at a time. Make one change and follow up with them, closely, to ensure that becomes a habit. And once they develop that as a habit, you move on to the next thing. because behavior change is difficult, and our population has many things that they have to do. Their lives are very busy, and on top of, their busy lives, they have to they have to do their treatments, take their medications. And so one small change at a time is my advice.
Okay, thank you. And Ken, do you have anything? Or Florine, do you have anything? No.
No, I need the tips.
Yes, we all need the tips sometimes. Okay, thank you very much. It was very interesting. I'm happy to be here with you, and we have to close it. Thank you again, and thank you for all for listening. Bye.
Thanks very much. Bye-bye.